Hello, my name is Clodagh O'Donovan and I'm the PCRN project manager within the research team of the All-Ireland Institute of Hospice and Palliative Care. As part of my role, I help support the development of the Early Career Researcher Forum and its 202 members on the island of Ireland. The ECRF provides members with opportunities to access peer and mentor support, develop links with senior researchers, participate in capacity building events, and share knowledge across disciplines. If you're not yet a member, I'd encourage you to join. You can email the Institute for more details. Today, we're delighted to have 4 ECRF members who will be sharing their research with us over the next 2 short sessions. We'll have 2 brief presentations before lunch and 2 directly afterwards. Each presentation will be followed by a very quick Q&A session, and I invite you to enter your questions for each presenter using the Q&A function as they're speaking so that we're ready for that Q&A session that follows immediately after. So our first ECRF presenter is Anne Jordan. For 4 years, Anne has been the service manager of a long-term residential centre for homeless older adults. She focuses on caring for, advocating on behalf of, and improving end-of-life care for this ageing cohort. She holds a BSc in occupational psychology and has completed her MSc in loss and bereavement through the RCSI and the Irish Hospice Foundation. Anne, the floor is yours.
Thank you, Clodagh. It's a real privilege to be here this morning to discuss the findings of my recent study. And good morning to everybody. I had a few technical issues last night, so I'm hoping I can share my screen without any hiccups. So, can you see that?
I can't, but we can share it for you if you want.
Oh, okay. If you could.
Yeah.
Oh, hang on. Let me just.
Oh, there you go. Kathy's just sharing it for you now.
Oh, perfect.
So if you just ask next screen and she'll pass it on.
Okay, brilliant.
Okay.
So the title of my study was Advanced Care Planning in a Long-Term Residential Setting for Older Homeless Adults, Developing and Evaluating Collaborative Planning of Future Care. Next slide, please. So why did I undertake this study? Well, as Clodagh mentioned, I've been managing a homeless service for over 65s for the last 4 years. And about 3 years ago, I undertook a review of end-of-life care service provision and found that really there was no structures or processes for residents coming to the end of their lives and for the staff who are providing care and support for them. So I identified gaps in practice for staff, gaps in knowledge, and real gaps in the documentation of advanced care planning for residents coming to the end of their lives. Also, because of the complex needs of the homeless older adult, many of whom have chronic mental health conditions, chronic physical health conditions, and many have very little input or support from family or friends. And often we've found that the only people that are supporting them or advocating for them is the staff providing the care in the service. So I sort of realized that it was really important to look at ways that we could improve the way in which we establish residents' future care wishes and goals. Next slide, please. So the aims and objectives of the research. The primary aim of the research was to investigate the experience and garner the opinion of residents and staff in relation to advanced care planning on a personal, social, spiritual and psychological level within the service. The objectives were to investigate the lived experience of residents and what matters to them in terms of future care wishes and preferences, to ascertain the priorities for staff. So what did staff think should be included in an advanced care document? To look at potential training requirements for staff. And fourth objective was to propose future actions and recommendations. Next slide, please. So the methodology used was the study. It was conducted using action research and more specifically a cooperative inquiry approach. So really I wanted to ensure that the study was a collaboration between myself, the staff working in the service and the residents living there. So I interviewed with 6 residents and I had planned to do a focus group with 14 of the staff team, but because of COVID restrictions, I ended up sort of changing and interviewing 7 frontline care staff. I also used really rich data from weekly team meetings and weekly residents meetings. And really this just gave us all an opportunity to have open and honest conversations around end-of-life care and what it meant for both the team and the residents. So the data was analysed. I used the Brown and Clark thematic analysis framework, and 4 themes emerged. So the first was the lived experience for residents. Many of the residents, they had a really clear understanding of what advanced care planning meant. And some of them actually told me during interview that they had documented some of their wishes a number of years before with staff, but I wasn't actually aware that this had gone on. It was before my time. And they said that they felt that these documents were either in files in the staff office, and some said that they were in their bedrooms. But anyone who brought that up in interview really felt that any of the wishes that were documented would be honoured and respected by the staff. The second theme was the importance and meaning assigned to funerals and care of remains after death. So I'll just give a little bit of context to this. During the study, 2 of the residents died quite suddenly and unexpectedly, and we had 2 very different experiences after their death. So the first resident, I received a phone call from the funeral director a couple of days after he died, and this resident had, unbeknownst to us, had paid for his funeral and had documented his wishes. So he wanted to be waked in the service. He wanted the staff to walk behind the hearse to the local church in the community, and he wanted to be buried at home in the family plot. And we were able to carry out those wishes because I suppose one of the main facts was that he had paid for his funeral. A number of weeks later, another resident died quite unexpectedly and very suddenly, and we soon realised that he had nothing documented. So the experience for him was that we had the service in a local church in town. He'd never been to that church. And he was buried in Glasnevin Cemetery in an unmarked grave. So this had a huge impact on both residents and staff, and many discussed what their wishes would be around funerals and care of remains after death. The third theme was communication, and for staff, this was a big piece in terms of, well, if we're going to have conversations around end-of-life care, when should we do it? How should we do it? And the second part of communication is sort of linked to the previous theme. Staff soon realised that residents did, have wishes that they wanted to be buried in certain places. Others wanted to be cremated, and this wasn't always going to be the case. So they felt that any conversations around end-of-life care or advanced care planning needed to be really honest and real. And the fourth theme was gaps in the existing service. So that sort of looked around the area of gaps in education and learnings, and improving advanced care documentation. Sorry, next slide. So there are some of the recommendations. Is just to investigate what other services are doing in homeless services, to develop and try and implement a document that's fit for purpose, Further investigation is needed on the when and how conversations should occur. And then finally is to give staff the tools in order for them to have these conversations with residents. So just last slide, this was a quote from one of the residents after his friend had died. Like his friend is to have it in the chapel here and in the local church. Yeah, please God, I won't know, but I will probably be looking down from heaven. I know you wouldn't disappoint me. Thank you.
Thanks for that, Anne. Just a few, if I just remind attendees if they can add their questions to the Q&A function, but I'm going to ask you quickly, what are your personal plans for where you're going to take this? Like, what are your next steps with this kind of work? What do you want to do next?
Further research, I suppose, Clodagh, in terms of, I suppose, collaboration with others to try and see how you could develop and implement a more fit for purpose advanced care plan. And then the whole area around funerals and care of remains after death, because finances comes into play, which I wasn't expecting to find that in when I was carrying out the study. So it's just to ensure that if somebody has a wish to be cremated or somebody has a wish to be buried in, in the place where they grew up, that those wishes could be honoured and respected.
Yeah, very good point. And I suppose, existing guidelines are there for the general population, but I suppose this is a very specific cohort. So, there's all sorts of concerns there, around language and around, I suppose, that whole financial aspect. How would you see that would be best approached?
Again, I mean, I suppose it's down to funding. It's down to sort of trying to generate more talk about that this is actually a real thing that happens in homeless services.
Okay.
Yeah.
Brilliant, Anne. Listen, we're going to, I appreciate that. Thank you so much.
Thank you.
We're going to move on to our second abstract now. And that is presented by ECRF member Dr. Aoibhinn Conneely. Aoibhinn is a specialist in palliative medicine who completed her training in 2018. She holds an MSc from King's College London, and she's currently an MD student in Trinity College Dublin. Over to you, Aoibhinn.
Hello, is my screen sharing?
It's not at the moment.
Okay, sorry, I seem to have done that. Sorry, now I was already... Oh yeah, I have it here. Sorry, apologies.
Brilliant. Thank you.
Now, that should be sharing.
Yep, perfect.
Okay. Sorry, that's gone to the last slide. Oh, sorry. Baby brain. Can I use that excuse? I'm on maternity leave.
Yes, you can.
Hello, my name is Aoibhinn Conneely, and thank you to the All Ireland Institute for the opportunity to present this work today. Today I'm presenting a piece of work where we attempted to estimate the palliative care needs of people experiencing homelessness in Dublin, which follows on quite nicely from Anne's presentation and obviously aligns with the theme for today. So today I'm going to present a very brief visual abstract of my work. And the background to our study is that we know anecdotally during our work as clinicians delivering palliative care that on occasion we meet people experiencing homelessness. Much of the research on this topic, including work that I conducted myself with Regina McQuillan a number of years ago, is qualitative in nature. So knowing there is a need, the next obvious question to me was, how big is the palliative care need from a service provision point of view? Has that question been answered already in the literature, and how complex a question is that to answer? Some people may make the assumption that deaths among people experiencing homelessness are frequently drug and alcohol related, and that there is the odd death from cancer or COPD. However, from Rob Aldridge's work in UCL, we know that people experiencing homelessness frequently die of the same illnesses as the housed population, but at a younger age. So what we did was we collaborated with Professor Joanna Ivers and Prof Joe Barry in Trinity. They had painstakingly obtained the data for deaths among homeless in Dublin over an 11-year period. So we got ethics to re-look at their data through a palliative care lens. In summary, there were 361 deaths over an 11-year period. The information we had was verbatim from their death certificate, which for the most part had been issued by the coroner. Two researchers converted this data independently into ICD-10 codes in line with WHO guidance, and then we applied methodology for estimating palliative care need at a population level. For those of you on this webinar, you are likely very familiar with this methodology. It has been refined by Fliss Mercia and applied at a population level in Ireland by Pauline Kane, Peter May and Karen Ryan, to name a few. Basically, it's a refined list of causes of death that could have benefited from palliative care input. The challenge with our data set was that in 82% of deaths, there was only a single contributing cause of death. And for those of you familiar with death certificates, normally there's a chain of events. This is very well described by the WHO, and an example would be bleeding esophageal varices as a consequence of liver cirrhosis, as a consequence of hepatitis B, as a consequence of intravenous drug use. So in order to account for this single contributing cause of death, we conducted a second analysis whereby we took deaths of anyone under 50 and asked the question, was there another underlying cause of death? An example of this would be respiratory failure in a 25-year-old. Respiratory failure is a cause of death that is considered to have palliative care need. However, in the context of this population, it was assumed that respiratory failure in a young person with no documented multimorbidities was more likely to be from an opiate overdose, and so this was recoded to drug use. Although this introduced bias, we felt it gave a more accurate interpretation of the data. So to cut to the results very briefly, on analysis 2, which was our more conservative estimate, we estimated that at least 25% of deaths of people experiencing homelessness in the Dublin population could have benefited from palliative care. This contrasts with an estimated 75% of all deaths in the general population dying from an illness that could benefit from palliative care. Although our numbers are small, you can see very clearly that as the age of those dying increases, so too does the likelihood of dying from an illness that could benefit from palliative care. And that ties back into Anne's research on older people living within homelessness. Why does this matter? This research matters because in this piece of work, we have moved from knowing there is a need to showing there is a need. So by combining this work with work such as Anne's and my own previous qualitative work, we can say to funders and service providers, actually there is a very significant and likely unmet need in the delivery of palliative care and end-of-life care to people experiencing homelessness, particularly among the aging homeless. Obviously, this was not a perfect study. There are quite a few limitations, such as a single cause of death and minimal multimorbidity on death certificates. The biggest limitation is probably taking a methodology designed for population level use and applying it to a subpopulation, which we did. To wrap up very briefly, we have demonstrated that there very much is a palliative care need for people experiencing homelessness. I think personally, if we incorporated multimorbidity, we would demonstrate a much higher need. And hopefully this will be one of our next projects. This research should be layered on top of other research that shows that health and social care needs of this population are extremely complex, in part due to ACEs and trimorbidity. Nobody should be dying in homelessness, but for those who are we adequately meeting their needs? From qualitative work, I don't think we are. The next step is to think, how do we best meet their needs as health and social care providers in the wider context and not just as palliative care services? But that's a discussion for another day, but food for thought. Thank you very much, and I am happy to take questions. I have some key references at the end of my slides if anybody is interested.
Great, Evan, thank you for that. And we can provide slides to people if anyone is interested. You can email us for those. Evan, that was very interesting. And I noticed you said that, obviously there's further research needed and ways of approaching that would be great. How do we best provide palliative care to people who are homeless?
I don't think we have the answer to that, but I think that it's a very interesting question, and I think it layers on the earlier discussions that we've had here. You know, we're not the only, palliative care services aren't the only people who provide palliative care. And people experiencing homelessness have incredibly complex needs, and perhaps us supporting the people who have those relationships and who are the healthcare providers there is perhaps where our role lies. There have been some projects. Caroline Schulman's group in London have done an interesting project where they combined with a hospice. They matched hospice and accommodation and tried to combine their skill sets. I think we have to be very careful in palliative care about not parachuting into places and you know, kind of saying this is how you do it, because people working with people experiencing homelessness know a lot more about their needs than we do. But again, it's all about collaboration and sharing skill set, I think.
So our third presenter is an ECRF member, Lisa Cronin, who qualified as a dietitian in Queen Margaret University, Edinburgh in 2013 and worked for the NHS in community and hospice care for the following 5 years. She then worked for Milford Care Centre, Limerick, and is now providing community care in Cork with the HSE. Lisa recently completed her Masters in Dementia in UCC. Lisa, you can start whenever you're ready.
That's great, Clodagh. Thank you very much. We'll just go into the slideshow. So thanks for having me here today. My name is Lisa Cronin and I am presenting my research entitled Accessing Specialist Palliative Care for People with Dementia. And as Clodagh said, I conducted this study as part of my master's degree in dementia in University College Cork, and that was in June 2021. So the aim. What was the aim of my research? It was to explore how people with dementia access specialist palliative care services from the perspective of healthcare professionals involved in the referral process. My methods. So my study design was a qualitative design, and that was based on semi-structured interviews. The population I used were healthcare professionals involved in the referral process, and this was set in a large working hospice and residential care facility. My sample was 10 healthcare practitioners, and this included specialist palliative care consultants, clinical nurse managers, specialist registrars, and an assistant director of nursing. And once the interviews were complete, I used thematic analysis to evaluate the data. And this type of analysis can be very beneficial in breaking down qualitative data with a deep understanding of what people are saying. So what were my results? I had 4 key themes, and I will go through each one of these in turn. So the first one was capacity for providing dementia-specific specialist palliative care. So specialist palliative care does not provide the same quality of dementia care as specific dementia units. Specialist palliative care does and should have a role in dementia care, but the experience lies in the specialist palliative care rather than in dementia care. And this was highlighted by participant 1 in my study. We're not experienced nurses in dementia care. I suppose we're not dementia specific. So I do think it is challenging when you have a dementia patient in a different area that wouldn't be R40. The next key theme was appropriate referrals and recognising need. A lot of people with dementia require specialist palliative input at a certain point in their illness trajectory. It can assist in managing physical symptoms, but can also facilitate important discussions and decisions relating to the patient's current and future care preferences. And this was highlighted by participant 6. Sometimes with dementia, I suppose a role might be in terms of planning for the future, like, for example, ceilings of care, the appropriateness of future hospital admissions. What could be achieved? What will be the benefit versus the burden? The third theme was inadequate and inequitable geographical distribution of services. So there's one issue being diagnosed with dementia or any other life-limiting condition, but where do people with dementia and their families and caregivers go for information or services? Even if the information is available in a person's locality, Are there enough services available, and are they easily accessible to the people who actually need them? And this was highlighted by participant 2. And I think care in the community is very limited. Resources are very limited. So I think even trying to get somebody to a clinic to see anybody, it's all very limited. And last but not least of my key theme is service integration and interprofessional collaboration. So this was arising from the data as a clear drive to integrated working. It was to supplement another part of care rather than to replace it, which is very important for the patient, as one person or one team cannot be the expert in everything. And this was highlighted by participant 3. I suppose the challenge is now, with all the medical interventions, just even the care. Where does specialist palliative care even fit in a person's illness journey? So, in conclusion, a needs assessment for specialist palliative care input is independent of the diagnosis. If people meet the criteria, they will be assessed by the specialist palliative care team. However, there are caveats known as grey areas. So there's a lot of components to consider when managing the referral process for all people with a life-limiting condition for access to a specialist palliative care service. The challenge really is to have a standardised format for equity for all and across all disease trajectories. This is very challenging and requires appreciating limitations, changing models of care that are well established, changing work practices, and looking to the health service for a more realistic, integrated way of working. Using the expertise in different areas is certainly beneficial and ensures person-centred care. And as you can see on my slide here, you will see more research is noted. And what is really interesting at the moment is the Model for Dementia Palliative Care project, which is looking at this changing model of care for people with dementia. And it's also worth noting that the HSE has started implementing the Integrated Care Programme for Prevention and Management of Chronic Disease and an Integrated Care Programme for older people, which are both welcome changes in the health service. So thank you very much for listening today, and I'm happy to answer any questions. And if you feel like contacting me afterwards, please do so.
Thanks, Lisa. That's great. Can I kick off the questions? I'm going to invite our attendees to enter their questions into the Q&A function at the bottom of their screen. But in the meantime, can I just ask you, why did you choose this topic?
It had been in the back of my mind for quite a while, and working in a really busy hospice environment, I got thinking about all the different disease trajectories and all the different conditions that people with conditions that we saw. And I wanted to answer my own question, so that's why I took it on. Thanks for that, Clodagh.
And did you answer your own question?
I did, actually, yes. I thought it would be a different answer, but actually what I figured out at the end of the study is just so complex and so interesting, and I think moving in the right direction of integrated care working is fantastic.
Brilliant. Thanks, Lisa. I mean, it's interesting that you can go into a research project thinking, like, having a question that you want answered and thinking you know what the answer is. And it's surprising how often that actually what you find with the data is that it's not what you expected at all.
Absolutely. Absolutely. That's why research is just so important, because you think you know the answer, but you really don't.
What was the most surprising piece to you, Lisa?
That's a very interesting question, Clodagh. The most surprising, I would think, actually, is how service integration is really beneficial for the service user. But what was really surprising is the amount that goes on in the background of that service integration and the changing models of care, and that does take a long, long time. So that was actually quite surprising, just realising how big of a scale the project is, you know.
Great. Thanks a million for that, Lisa. I appreciate it. We have one more question here, and I'm just going to ask it. It was mentioned this morning how a recent report shows more people are dying from dementia, and it could be linked to how it's being recorded. With this growing need, we're having two questions. Another one just popped up there. With this growing need, what would you do to improve palliative care?
Can you repeat the question, actually, Clodagh?
So what would you do, because it seems that recent reports are showing that more people are dying from dementia, which could be because of the way it's being recorded. But with this growing need, what would you do to improve palliative care for that cohort?
I think that's all about kind of integrated working as well, and kind of sharing expertise, because I think we can learn so much from those who are experts in dementia and those who are experts in specialist palliative care, and actually providing that time and that training and working together is really, really important. Now that does happen already, but I think actually more of a highlighting that issue and that it can be done would
Brilliant.
be one of the ways I would do it.
Thanks, Lisa. There is another question there in the chat. You might answer that person directly, but we need to move on, unfortunately.
No problem.
So
thanks very much.
Thanks for that, Lisa. Our fourth and final ECRF presenter is Dr. Deborah Muldrew, a research associate in the Institute of Nursing and Health Research at Ulster University. She holds a degree in psychology and PhD in palliative care and associate fellow status with the Higher Education Academy. She's researched within the palliative care area for over 8 years, and her outputs have directly influenced clinical practice and health policy. Over to you, Deborah.
Thank you. Let me just get my screen shared. So hopefully that's come up okay.
Perfect.
Brilliant. So thank you for the opportunity to speak today on public engagement and consultation with advanced care planning. And I'm going to share some of my findings from a virtual workshop. So just to start, I want to begin with the definition we have used for advanced care planning in this research and in our project. So we've defined advanced care planning as an activity that enables adults at any stage or health status to discuss, identify and share their personal wishes, feelings, beliefs and values regarding either future legal, financial, personal or medical care. Policy and research advocates that advanced care planning should adopt a whole community approach. This means advanced care planning is everyone's business and not just for when you become unwell. And we believe that by upstreaming the advanced care planning discussions into usual health promotion activities, we can begin to normalise and reshape how we discuss future wishes. However, we also recognise that not everyone has equal access to an engagement with advanced care planning, and this can be influenced by health literacy, cultural, social beliefs and socioeconomic position. And if you'd like to find out a little bit more, I've included the QR code to Dr. Davies' systematic review and meta-analysis, and it's about socioeconomic position and healthcare use at the end of life. And as an early career researcher, I find this really beneficial to read. So, on the basis of a whole community approach, I received funding to host a public engagement workshop during Palliative Care Week to discuss advanced care planning. It was free to attend and could be accessed via either smartphone or computer using Microsoft Teams. The workshop consisted of 3 components. Firstly, we used Mentimeter, which is a live online survey tool to capture currently held perceptions on advanced care planning. We then compared these results in real time with the data from the Northern Ireland Life and Times survey. Secondly, we used breakout rooms for personal reflection on what advanced care planning means to me as an individual and how you would like people to remember you. And then finally, we had an update from policymakers on advanced care planning consultations, specifically in Northern Ireland, including how to get involved. In total, 88 people registered for the workshop, 53 of whom attended, and of these 53, 34 participated in the research through Mentimeter. So what did we find? Well, compared to the Northern Ireland Life and Times data, workshop participants demonstrated a stronger understanding of advanced care planning, including the importance of engaging when you're in good health. Workshop participants were more aware you did not have to wait until you were unwell to engage with advanced care planning conversations. Secondly, the ability to change your mind. Workshop participants were very confident they could change their mind about care decisions, which was not a confidence held in the Northern Ireland Life and Times data. And finally, the point in planning. All workshop participants saw the benefit in planning, whereas only half of the Northern Ireland public did. During the breakout rooms, artist Gwen Stevenson listened to the discussions and responded with an art piece entitled Heartfelt. And this spoke to the heart's desires to make a positive difference in the world and be remembered for your love and kindness. And the original piece is going to be displayed in the University of Ulster, and I've shared the digital memento on screen. So what did this mean? Well, firstly, we found virtual workshops to support the inclusion of a diverse and geographically spread group of participants. It tied into previous research that found smartphone use to be feasible for people of all ages, when age is often cited as a limiting factor for engaging in online events. However, we did acknowledge that people without internet access would have been absent and therefore not represented at the workshop. We also found that people who were motivated to engage in advanced care planning events were more likely to have a greater understanding of advanced care planning and therefore were more likely to take action. However, this does mean that efforts are still required to engage those who do not see the relevance of advanced care planning or who have previously felt excluded or if it wasn't for them. I've also included the word cloud of participants' responses to what does advanced care planning mean to me, and you can see some of the key ideas were peace of mind, control, preparation and reassurance, and these were something we felt should be equally afforded to everyone. So just to finish, I'd like to thank my team, Professor Sonia McElfatrick and Dr. Felicity Hassan, for their support on the funding application and for organising the workshop. And also to the funders, which was Ulster University's Early Career Researcher Impact Fund, and the Advanced Care Planning Policy team in the Public Health Agency, who were instrumental in the development of materials and the organisation of the workshop. And just to thank as well all of the organisations who supported the distribution and dissemination of the event. I've highlighted on screen the All-Ireland Institute of Hospice and Palliative Care, the Palliative Care Research Forum in Northern Ireland, the Patient and Client Council, and the Department of Health Northern Ireland. And if you have any questions, I'd be very happy to answer them now. Thank you.
Thanks, Deborah. Just a quick question from me to start, and I would invite people to enter their questions into the Q&A or the chat. What was your biggest learning from that event? What did you take from it?
I suppose for me, I would sometimes worry that doing an event online, we had originally planned to do it face-to-face, but with the restrictions in place, we had to move online. And I suppose one of my hesitations or concerns would have been during the breakout rooms that because it was online, people weren't maybe going to engage to the same extent, or people were going to hold back a little more. And actually, this wasn't the case at all. So we find people in the breakout room I was in, certainly, and I had feedback from a few of my colleagues as well, like people were very open and very honest and very willing to share their like personal experiences and things which you maybe wouldn't think people would be comfortable sharing online. So for me, I didn't see going online as much of a limitation as I thought it could have been.
Brilliant, that's great to see. We have a question here. They say, please, what are your views for advanced care planning for people in countries where there are no legal framework supporting same? So, do you have views on how to help people maybe develop a plan for advanced care planning? I know it's a tough one, but just maybe... That's
a massive question.
It is, it's a huge one.
Off the top of my head, if I had an answer, I would love to share it, but I guess a lot of the bit that really interests me and what I would love to be involved in more and I'm keen on developing is even before that, the public perception and the public awareness of advanced care planning, and getting people comfortable to talk about it and have it something that people would be willing to share informally even before we move into the formal stage. I think there's a real opportunity to start to change public perceptions and how general people feel talking about the future.
And that leads on to a question here from Helen Kerr. She's saying, how do you think we can engage those who are less motivated and interested in advanced care planning to discuss this topic? How can we engage those people, do you think?
And so this was the question I put at the end because I don't have the answer for this one. And I would love to, but I think in terms of engaging people who are less motivated, it's about taking it out of the space where people usually interact with the concept of advanced care planning and moving it somewhere where it maybe feels more comfortable. And I've seen some really nice work done abroad where they do public displays and art galleries and museums and, bringing people in spaces that maybe feel safer or more public, and away from a time when you're in either very emotionally fraught or there's something going on that's maybe giving it more of a negative spin or more of a panicked spin. I think if we can take advanced care planning earlier, have it as something which just is a thing that people talk about in social spaces, that could be a good way to get in.
Excellent. That's really good. Just one tiny follow-up question. Do you think, and we'll very briefly, if you wouldn't mind, just like 20 seconds. Do you think there would be a big change in people's advanced care planning, if it's made when it's in good health? Do you think, like say the advanced care planning made while you're in good health, is that very different to the advanced care planning that you would make when you have a life-limiting condition?
I suppose it was something we did talk about in the breakout rooms, and one of the questions posed was what's important to me now and what's important in the future. What's my legacy? How do I want people to remember me? And that was something that doesn't seem to change. So no matter what stage you're at, if you can tap into what's important to you now and what do you want people to remember you for, that part of it is something that might be consistent. So there will be specific health-related issues that may change over time, and your view may change depending on how close or how far you are from a situation. But I think that in itself is one aspect of the advanced care planning definition that we're working with. And if you look at some of the broader stuff and some of the sort of the different aspects outside of the pure health decisions, I think there is a consistency over time about what you want your legacy to be. And so that could be something, and even that in itself could be a way into maybe some of the more challenging conversations. And to go in with something a bit softer that people relate to at any age, at any stage.
Great, thanks Deborah for that. So that concludes the ECRF abstract session. Many thanks for your engagement. I hope you agree that we enjoyed 4 interesting and diverse presentations.